This is FX Medicine. I'm Andrew Whitfield Cook, and I'm here with my colleague Bec Gill. How are you, Bec?
Yeah, really well.
Now, day 4 of the symposium. We've just listened to Lara Briden this morning give her plenary and her case histories. There was Jennifer and Cindy. And then, of course, a special presentation by Dr. Mark Donoghue himself on ApoE, which was thoroughly interesting, and I am still confused. I still have to go back, and I am going to wait for the recording to re-watch that because I still get caught on it. But less about that, more about Lara. Every single time that woman opens her mouth, I have to throw out something that I thought I knew.
Ain't that the
I
truth?
have got it wrong in so many ways.
Yeah, I hear you. Ain't that the truth? I think every time she speaks, for sure, I realise that there's so many more things that I don't know.
Absolutely. Oh, and, you know, I think one of the things that Lara really highlighted to me today, as she did with her talk with Kira Sutherland when she did that with the ATMS, it was 2019, God, so many years ago, was that the oral contraceptive pill bleed is not a natural menstrual bleed. It is a drug withdrawal bleed. And it's a pow. We have got it wrong. So wrong with women's hormones, you know.
And that is, isn't it? That is exactly what Lara is a pioneer for. If you walked away from today's session with anything, it is that, I mean, we already know that she's very passionate about women's health, but she is absolutely in the pursuit of a change to the narrative or the paradigm that kind of exists around the oral contraceptive pill. I think that, how did she put it? She said something like, you know, let's be realistic, it's 2020 and, you know, you can have, self-driving cars and we're still using the same contraceptive measures as came out in the 60s, something along those lines.
When it was supposed to free women's lives. Has it? Or are they really just shanghaied to a pharmacological model of suppression of their natural hormones?
And
it's not.
Given how utterly complex female physiology is, she also made a really good point. Yeah, she really made a good point today, which I probably hadn't thought about it this way, but you know, women are only fertile for a couple of days per month. Like, it's physically only possible to fall pregnant for the most part in a couple of days per month. And yet men are fertile 365 days a year. And so we've always pursued women to stop their stuff. And also the other thing she highlighted was just how important it is to women's health and longevity, their immune function, their mood, that is combined with ovulation. So I hope that more people listen to her message, more people buy her book, and particularly
more young women.
I
really hope that the period repair manual becomes the every woman of the new generation.
I flick through this all the time. It sits, actually, the only other book is my Braun and Cohen that sits on my desk 100% of the time.
Right. So much. One of the big lessons again that I learned was her message about that it takes up to 12 years for a woman to settle into robust ovulation cycles. So if you suppress them at an early age, because of ease, because of whatever, because of the medical preponderance to the oral contraceptive pill for everything, whether it be moods or whether it be acne in younger women, that it's all it's going to do is delay that woman's time to settle into a robust ovulatory cycle. And so again, it's like, what are we doing? What are we really doing?
Well,
so many great messages. It will be something, Lara's talk will be something that I will replay and replay and replay again and again and again once I get these recordings.
Absolutely. And I mean, how many generations now are we into the various oral contraceptives, for starters? And then furthermore, which was touched on a little bit today in the questions, but like how much further are we also, how many generations are we also into assisted fertility practices? Not to say that one's hand in glove, but obviously as science has developed, now we have answers or some solutions around helping women to fall pregnant who may not have otherwise done it. But what we don't know is what's been the kind of transgenerational impact of shutting down, well, basically putting, what she calls it a chemical menopause. We're putting women into chemical menopause for in some cases, decades. And then expecting their bodies to just come off the pill and respond and achieve a pregnancy, no problem.
Yeah, and wondering why they don't have these robust ovulatory cycles. It's like everything makes sense, and it's like there's so many aha moments whenever Lara speaks. But I need a search mechanism.
Her brain.
Bang.
I haven't felt that way about your brain over the years, but yeah, wouldn't it be nice? Control F, please find that thing.
And one of the other important messages from Lara was the luteinizing hormone to follicle stimulating hormone ratio.
Yeah.
Really interesting stuff for differential diagnosis of PCOS versus hypothalamic amenorrhea.
Yes.
Really, one of the differential diagnoses, I should say. But really interesting also that so many, when we talk about the case history, and I think it was Jenna? No, Cindy was the second one, who had PCOS but was diagnosed as having hypothalamic amenorrhea by 3 GPs plus a gynae. And it took an endocrinologist to successfully diagnose her polycystic ovarian syndrome. The 3 GPs and the gynae had all done ultrasound as diagnostics for PCOS.
Again, so we've really, highlighting the complex.
I think the call is to be the experts so that we can actually say, no, that's not right. Yeah.
She definitely did a really good job today at kind of helping to develop and you can't even call it a pathway, because it's like you go here and then do you turn left or do you turn right? She's created kind of a maze, but a way of like, okay, if we get to this point and we discover that we've got this blood test or this symptom or whatever it might be, then we're going to go this way and we're going to treat it this way, or we're going to approach it this way. So I think it's just one layer of the onion, really, like to understand women's health. But today was a deep dive, definitely, into the difference between PCOS and hypothalamic amenorrhea. Hopefully I said that correctly. Which her patient case studies really illustrated like how to pick out the difference between the two as well. And the polls that she put up that said, what is this patient? And to see like, that the audience, there was, a big audience, and they picked it out. They did a great job.
And did a really good job, which says heaps, doesn't it?
Yes.
I mean, this was seen even with sort of like a grand rounds done in Sydney. And it was the natural health practitioners that were getting these answers to the concepts right. And it was the GPs which were lagging and going, what are they talking about here? And this was spoken by orthodoxy. This was taught to them by orthodoxy. So it's not like it's a leaf-waving sort of opinion. This is medical opinion.
Yes.
Scientific fact. So it just speaks volumes of how much our professions know where we should stand firm, and indeed where we should be the vanguards for our patients' health. And you could see that in Lara's writings, in her referrals or requests to the medical practitioners that her patients were dealing with.
Yeah.
I'm part of her team.
Yes. And that it's important to have a team.
Yes.
Some of those really complex patients that she was showing, they had a GP, sure. They had her, and then they also had, a series of specialists that they needed to see, psychologists, endocrinologists, OBGYNs, like whatever it might be, that, you know, healthcare doesn't have to occur in an individual silo, that we really need to focus on the fact that to keep people well, particularly those with chronic disease, you need to institute a team around you that help to advocate on your behalf. I mean, you and I have talked about this at length, about how we often sit here and scratch our heads at how do people navigate these muddy waters of healthcare when, you know, we struggle with it, and we have knowledge and we have connections and contacts and all of that. So you really start to understand that, you know, patients need advocates. They need people who are going to strip back the layers and start to go, oh, hang on, is that so? Is this exactly what's happening?
And it's really interesting. You know, I've actually had to do this recently on a different level with a relative, close relative, and it's really interesting that when you stand up and you go respectfully, no, that's not right, or I disagree, I don't think what you're saying or doing is appropriate, then you get them questioning their physiology, their clinical decisions. And as long as you have the right information, then you can be the one who can guide that patient back to health, rather than just seeing them on this horrible treadmill of, as you say, chemical castration.
Yes, well, I mean, it does start there, doesn't it? She made a really good point about ovulation being important, and like you said, resetting or settling women into their hormonal cycle from, you know, when they're teens, and that it's a huge issue that now that they're basically putting girls into these kind of chemical states of menopause to solve something such as acne, before they've even explored some of the other avenues that might be causative factors.
Like avoiding dairy.
Yeah.
I mean, whoa, why not just try it?
Yeah.
I mean, if it doesn't work, hey, it doesn't work. But rather than long-term oral contraceptive drug therapy, if that's your only reason for the OCP, bit of dietary modification maybe, do.
Yeah. But because I suppose we can see that women haven't had this opportunity to settle into their cycles and to, you know, be in tune with the timing, the symptomology, the things that their body's trying to tell them around, you know, are you ovulating? Are you about to get your period? All these different things. So by sort of removing that from the equation, everyone's so far removed from it that now I do wonder that are some of the diagnoses that we're seeing for things like mood and behavioral issues and depression, anxiety, all of that, you know, half the time maybe it could be, I haven't got any factoids around that, about half the time, but very often let's start looking at the contraceptive pill as like this straw that broke the camel's back. Yeah,
absolutely. I mean, Mark brought that up in his podcast with Lara earlier, talking about, you know, how there was a loose study done in rats on 2 milligrams of fluoxetine, Prozac, and so it was just extrapolated to humans, and all of his colleagues were immediately jumping on board for everything to do with anything they were scared of in the female, which is a lot. So we're just dishing out 2 milligrams of Prozac for everything. I mean, it's insane when you think about it. It's insane when you look back. But one of the other points, sorry, just to tie off what you were saying there about being aware of your body. Listen to your body. I mean, how many times have we heard this? Lara's book should be on every coffee table, let alone women. Men need to learn about this.
Well, yeah, it's true.
Absolutely. Men who care want to learn about why things are going wrong, how they can help. You know, is it something that the, you know, male is putting excess stress on the woman, you know, by not hanging out the washing and doing the dishes and cooking some dinners and easing the woman's stress, because now they're both the caregiver and the breadwinner as well. So there's men need to learn about this sort of stuff. As I said, I think this should be the new everyone.
Yes, it's not secret.
Which would win by a man, I might say.
Yeah, it needs, the taboos need to go, don't they? I think, you know, at the end of the day, It just there needs to be open conversation and comfort, I think, from both men and women.
Absolutely. There were so many really practical points that Lara covered. And you can obviously tell she's a clinician who walks her talk, but also speaks to patients every day. And the answers that she gave to the multitude of questions that came up speaks volumes to how much we need to learn, but also speaks volumes of Lara's expertise.
And also, like, sometimes, there were a lot of different scenarios being thrown her way. And sometimes the answer was as simple as, okay, they're not ovulating and that needs to be addressed. Like, bam, answer done. And then other times there was, okay, well, we need to consider, SIBO, the gut, inflammation, diet, all the things. I did, when you were saying that, like, walking a talk and talking the various things, did you write down a couple of, like, aha moments? I wrote down like, for a non-ovulating vegan, zinc and iodine. She's like, that it was an
I would add B12 there.
An ovulating, but an ovulating combo, which I was like, oh, that's interesting. I'm going to write that down. What about you?
Well, really interesting to me, like, the aha moment was when we're talking about the prevalence of iodine deficiency in the eastern states of Australia, why not Queensland, but also New Zealand, and that it's we know that this is a soil issue because it's a continental issue. So therefore, it's not something that you can eat good food and get. It's not in the soil to be given to the vegetables or the other foods. So it's a supplemental issue, and we can dramatically affect not just hormones, but also intelligence. And we've seen this in trials. So it's now when you see it, that it is the first supplement. Folate wasn't a supplement. Folate was food fortification. It is the first supplement that is guidelined, bad syntax, I think it was from January 2010.
Yeah.
I know.
That women, you're talking about all women who are...
Forgive me, all pregnant women should be supplementing with 150 micrograms of iodine so that their fetus gets it. And we should be looking at this in our kids as well. And that, we've seen this now in our women. In our women, as though they're owned. In women.
Yes.
Misogynist.
And again, I know I said this in another session, but it's again one of those minerals, much like B6, magnesium, and zinc. You start to look at the foods. If you can't tick, several of those foods that you eat on a regular basis, you're not getting a good supply unless you're a good consumer of commercial breads, because obviously, because of these health measures, Australia does fortified bread now to try and mitigate this as a risk.
Yeah, that's right. So when you're talking about aha moments, there was a great aha moment which somebody actually posted up on the message and said, finally, we now have a mechanism for why licorice works. And that was the site 17A1.
I think it was me who said that, actually.
Oh, was it?
Yeah, I was like, oh, because, licorice and peyote. I mean, I remember learning about it at college.
Oh, you were the best.
Doesn't know nobody knew why it was such a, strong combo, but, those Chinese medicine people, they knew a thing or two. And then you actually put that up and I was like, oh, wow.
Yeah. But also, Myositol, we've seen it. It was first seen in what was a Glucerna, which was used for type 2 diabetes, that sort of meal replacement. And since then, it's just escalated. The interesting thing to me is with Myositol is the dose. It appears that when you've got insulin resistance, you really need this gram dosage. Don't muck around with a milligram type dosage. And that, I think most practitioners support that. So we really need to be looking at proper dosage to have a good effect, but an effect that's really, really good. And the other one was Berberine, gone head to head with metformin. So for those people who can't handle the diarrhea and the stomach cramps from metformin, which is one of the quickest and most prevalent adverse effects from taking metformin, then what about taking Berberine, which might indeed have an opposite effect? Might regulate diarrhea, might regulate stomach problems.
Yes, I was furiously writing down, there's so many points I've started to write and I haven't finished writing exactly what I wanted to finish writing, because then she moved on to the next point and I'm like, oh no. But yeah, I thought it was interesting with the berberine. She was talking about, and you might recall this a little bit better, but something along the lines of the way she does the dosing is 5 out of 7 days.
Yeah.
And then cancels it. Yeah.
Yeah. So, I mean, there is an issue or potential issue about, berberine knocking off good bugs as well as bad. And that's why it tends to be cycled in SIBO, for instance. It's interesting, though, that the dose that she was using ties in exactly with the dosage that's successful for hypercholesterolemia. Sex steroid hormones, anyone?
Steroid,
it all goes round and round and comes
blood
back.
Sugar, insulin, blah, 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 blah.
Yeah, blah, blah. But it all comes back and back. What was the other one? The other one, the case history one, that's right. So that was Jennifer. This was the lady who had a really high alcohol intake. She saw her 4 months and then didn't see her for another 18 months or something. What was really interesting and sad to me is that she was on so many courses of, well, ostensibly she would have been on multiple courses of antibiotics because of multiple incidences of tonsillitis. Now, what's interesting to me is that if she was on any progesterone or even progestogen, that the amoxicillin will reduce that level. So she's always trying to sort of push herself uphill, unfortunately on a medication which will reduce the levels of the supposed thing that will give her any aid. Now, I don't know if she was on micronized progesterone during that time. I'll have to listen again. But I don't think that's so at that stage. But it's just really interesting about the use of antibiotics can reduce these active hormones.
Yeah.
So what are people doing to their body? And what was one of the simplest things? Reduce dairy.
Reducing dairy, yes. And cow's dairy was the important part there. Like, I know as soon as and that happened in the podcast the other day as well, as soon as she mentioned no dairy, the questions sort of started to fire up. Does that mean you can't have goats and sheep and this and that? And it was to do with the A1, A2 protein. So cow is a no-no, but the other ones are okay.
And what about A1 to A2? Any difference there? Is it the beta-2 casein?
Yeah, it was to do with the A1 and A2. Don't get me to quote on that at this time of the afternoon on a Sunday, but yes.
No. And one of the other ones is one that I've said this for thyroid issues about using the simplest test for them as the most sensitive marker of actual bodily effect, and that is with thyroid. In thyroid conditions. So she was talking about with measuring progesterone, measuring the release of the follicle, and that was the increase in temperature. Just the simplest measure can give you the most profound information, as long as you know the physiology behind that. There, when you have that 0.3 degrees increase, you have released an egg.
Yes. There was a lot of discussion happening actually about, apps. And then what was so interesting, and I remember commenting, like, my mind has just been blown. There were several people talking about a Bluetooth thermometer. And so I opened that up. I'm going to have to look that up. That's so fascinating. Didn't know that such a thing existed. One of the other things that I know I wrote down was that women have a bit of benefit over men in the preservation of their gut lining, because estradiol preserves or improves gut lining. So if you're low, then if by boosting it you can improve gut lining. Fascinating. I did not know that. Absolutely.
And yet, contra to that, I always thought that it was estrogen which was the proliferator, and so it was estrogen alone which was beneficial for cardiovascular health and bone health. Progesterone, it seems, is the better one for bone health there. Now, I've got to learn some stuff. I really do. So for anybody watching or listening this, I mean, you all know Lara, I get that. but man, this was something to learn from. And I would just invite you that we're going to be excited and enthralled by further talks from Datis Karazian, and we've got Amanda Archibald back again. So, I mean, Datis blew me away in our first podcast when we were talking about autoimmune disease.
Yes.
Wow, he's done a lot of work, which can, I think, really help natural medicine practitioners to help their patients with autoimmune disease.
Yes.
Really interesting stuff.
He's probably not been, he may not be well known to our Australian audiences because I believe he hadn't ever done any keynote speaking for an event down here before. But yeah, very excited. I mean, yeah, right. The podcast we did with him is amazing. His website is amazing, and also
that you can do, yeah, brilliant.
Yeah, just so, and another one that you're going to be absolutely thrilled that you can go back, rewind, start, pause, stop, because he talks really quickly. Really
quickly. If you listen to our podcast on FX Medicine, you'll hear. Yeah.
So true. Anyway, so that's who is up next, in fact. So for the third consecutive weekend in June, next week we've got on the Saturday Dr. Datis Karazian, who's going to be talking about hypothyroidism and also how to evaluate Hashimoto's and hypothyroidism with his case study sessions. And then on Sunday of next week, we have, as you said before, Amanda Archibald doing her second plenary and second workshop session as well, or on the culinary biochemistry. So I believe she's in a deep dive into the methylation, the biopterin, and the, what's the third cycle that I'm forgetting?
Methylation,
biopterin.
Transulfuration, biopterin.
Transulfuration must be.
Yeah. And also we've got a special presentation from Amy Skilton as well on SIRS and mold damage in buildings. So that's on the Saturday, yes?
That's the Sunday.
That's the Sunday. Forgive me. Gotcha.
So much like today, where we had Mark delivering a session at the end of all today's proceedings on ApoE. Amy's session will go right at the end of the whole day's worth of workshops, and it'll be on SIRS, water damaged buildings, and the impact that has on hormones.
Oh, that'll be really interesting.
Very.
Can't wait to hear.
Very.
Can't wait to watch.
Yes. So that's it from us. We will see you back here next week.
Next weekend.
Yes.
This is MX Medicine, and we're Andrew Whitfield Cook and Bec Guild.
You got it. Bye, everyone.